things of course will be easy for you. And it is a breach in the posterior capsule which is not so sweet like this chocolate. And every patient with irregular posterior capsule must be carefully examined. Already Dr. Kulkarni has explained, and as a surgeon we have to have an eagle eye on these cases of ocular trauma, previous surgical procedures, and those patients who are on chronic use of medicines. We have to see few, especially polar cataract also. And as far as imaging is concerned, of course, B scan is very much helpful in detecting these cases which are at risk. And best is 20 Hertz ultrasound. So we have to be careful at every step while doing surgery, especially doing CCC. We have to have an intact CCC. Doing hydrodissection, we should not be aggressive. Doing hydrodelineation, we should be, do it in steps, or in risky cases, we should not do it. Growing, we have to, if the, burst phaco mode or less foot pedal control or beginners, they can cause PCR. And irrigation and respiration, if the tip should not be directed toward the posterior capsule, and, this thing, the unusual sign, they must draw your attention. Management is, early recognition is important. Optimal management and outcome, that depends on early recognition. And you have to have an eagle eye on sudden deepening of the ACs, try-on PCs, sudden improved red reflex and tremorlessness of the nucleus, or difficulty in rotating the previous, this mobile nucleus, which were pupillary slabs. If there is vitreous strains in the AC, if the lens is tilted, or fallibility of the nucleus is poor, or pupillary margin is moving. So these two things should be in mind, whether the vitreous is present or not, or whether we should go with the surgery or we should convert. And all this depends on hardness and the size of the nucleus, size of the pupil, maintenance of the chamber depth, and level of the surgical experience. Principle of management depends on two. We have to stabilize the anterior chamber immediately, take deep breath, stabilize the chamber, and then assess what is to be done, what not to be done. If suspected, then we should not withdraw the instruments suddenly, because this will further aggravate the situation, and we should, second instrument should be carefully withdrawn with AC formed. Immediately we should have low settings, less vacuums, low flow rates, and low irrigation pressure. It is always better to go slow in the right direction than to go in the wrong direction. And then again, if vitreous loss is not there, the primary aim is to prevent enlargement of the tear and prolapse of the vitreous into the AC. In nutshell, without vitreous loss, we can complete the surgery. If nucleus pieces are hard or big chunk is there, we can convert. We should reduce vitreous hydration by keeping the parameters low. And once the cortex is removed, we should always make sure that whether we have to do anti-vitrectomy or not, vitreous is not there, triamcinolone has to be used. And if at all vitreous prolapse is there, that should be removed first hand, and irrigation aspiration should not be done that vigorously to avoid further damage. And depending upon the situation, appropriate IOL should be chosen. If there is a vitreous loss, then the management slightly differs. We have to make it the situation like it was without vitreous loss. We should use OVD, and nucleus fragments should be removed, and bimanual vitrectomy should be done, and only then we should go further. If there is a problem or we are not able to manage, then these are the things. And if part or whole of the nucleus falls in the vitreous cavity, we should not fish around them. It should be removed with the retinal surgeon as your savior. So pulse are there, that you should have a ready anterior vitrectomy at least in your setup. We should avoid hydro procedures in difficult cases. We should lower the parameters if there are suspicion of the PCR, and we should avoid changing the nucleus with the phaco probe, and we should not panic, and we should not hesitate to seek help. We have to be Abhimanyu. It is a small video where few things went wrong with me also. It is a very tense and stretched capsule. See, this is basically not intact CCC, the first step which I was mentioning. Then surgical approach, we have to be very slow. Soft cataract was there, power is very less, vacuum low down. So without disturbing anything, I have not removed the phaco probe, first filling the chamber with the visco and then only removing the phaco probe. This is the rent, slow irrigation aspiration, slow removal of the cortex. So there's a big rent. Here, the mistake I made, I would have implanted 3-piece IOL, but I could manage implanting this. Thank you.
Thank you so much.
Last but not the least, I'm going for ARC member, Norjon. Please support me. Thank you very much.